Well, the initial role, I suppose, would be diagnosis and appropriate use of resources. So the most important thing is that you need to give them time, and that doesn't necessarily need to be time altogether. So initially you're making a diagnosis, and they may have a little bit of shock. They may go into the so-called Kubler-Ross stages, and one of the first stages of that is denial. So he's mad, I don't have diabetes at all, that test was wrong, and you need to be very, very careful, because deniers will often disappear and may not present for another couple of years with complications. So you need to keep a track on those. The next thing is anger. It's somebody's fault. How dare you? And then you may get depression. I've diabetes, I'm going to die. It's awful. Why me? Before finally, the acceptance, okay, I've got diabetes, what can I do, and stuff. So, you kind of go through those phases, and that's something that you're going to have to do yourself. So other members of the primary care team are very, very helpful. So we tend to refer, for example, everybody should probably attend an information course. So CODE or Desmond would be the kind of commoner ones for people with type 2 diabetes. And they're run and they're very easy to access, and by and large they're free. You would also tend to refer them for retinopathy screening, and we're very fortunate that that's now available, and it's run by the National Cancer Screening Service. So they have a call and recall service once they're into it and they're sorted. You then need to do a fairly full kind of checkup to just see where they're at. So you would look for other, their history. Have they got some kind of other vascular history, such as, ischemic heart disease or whatever? Have they got comorbidities? Do they smoke? Have they hypertension? Do they have dyslipidemias? Are they obese? From their obesity, have they got other things such as maybe osteoarthritis that prevents them from exercising appropriately? Do they have other conditions such as COPD that might have been brought on, other kind of comorbidities? So you kind of see where the diabetes lies in the context of all of this, and you try to deal with it holistically. The most important part of managing the diabetes really is the hearts and minds of the patient, because at its fundamental and the foundation is the patient knowing that they have to change their lifestyle and their eating habits and their exercising habits, and getting in with them, acting as partnership, going forward into the breach hand in hand, with the patient taking responsibility for the condition. And really that's kind of your goal. So then what we would do is we would usually bring them back to the practice nurse for a full diabetes checkup, which is the nuts and bolts. So we get their, we weigh them, we dip their urine, we send the urine off from albumin creatinine ratio to look for microalbuminuria. We do a EGFR to check for renal function. We obviously do their blood pressure check for something like 40% of people with diabetes of hypertension. Combination of hypertension and diabetes, it's very nephrotoxic, so we need to get in there early. And we need to try and stop them smoking, and we need to look at their alcohol intake, and we need to take off their shoes and socks, check their feet, make sure that they have good circulation, they have good nutrition to the skin area, and also, the feet are very, very simple. Look for monofilament sensation using monofilament proprioception, vibration, sense, and then talk to them. Very important to talk to them about their feet. About 12% in the US of diabetes patients will have diabetic foot ulcers. And a significant number of those will end up having amputations, and once you have that, your quality of life goes way, way down. But in our practice, with approximately 120 patients, we have no active currently ongoing foot ulcer, and I think in the 25 years we've had about 2. And we've picked them all up, and we've got them actively treated, and there's a lot more. So with very simple, low technology tools, you can do so much for your patients with diabetes and enhance their quality of life and ensure that they live a full life that's free of complications, or at least free of the manifest effect of complications. They may have background diabetic retinopathy, or perhaps a certain degree of diabetic retinopathy, but their vision isn't affected. They may have a degree of peripheral neuropathy, but they're able to walk, they're able to run, they're able to exercise, they're able to swim. And finally, to ensure that specialist services are used appropriately. So, for example, if somebody has podiatry issues, to ensure that they are referred appropriately to podiatry, perhaps referred appropriately even to chiropody. For example, elderly patients with arthritis who have difficulty in doing their own chiropody, it's best to ensure that they are able to access community-based chiropody, which in a lot of cases is subsidised and may be freely available or available at much reduced cost. And then other services such as the vascular surgery, or such as ophthalmology, or the renal clinic, or whatever. And then for those patients towards the end stage of their illness, where they've got fairly advanced disease, got difficult to control blood sugars, in that kind of situation, it's very appropriate to refer them to the endocrinology clinic to consider maybe getting help with managing their sugar control.